Hi everyone, my name is Alex Kreger. Last year I was a senior at Sugar Falls High School, managed to graduate, so this year I will be a freshman at Duke University. This summer I worked as a science intern in the orthopedic department with my mentor, Dr. Mark Freumsen. We worked on a project entitled Developing a Novel Risk Stratification Model to Predict Resource Utilization and Outcomes After Total Joint Replacement Surgery. So first we need to look at the current climate of our medical system. So as many people know, spending for national health care and surgical healthcare expenditures seem to be continue to rise at an alarming rate. In 2008, the national healthcare expenditure was 2.3 trillion US dollars. This constituted 16.2% of our gross domestic product. And in 2019, this will be projected to rise to 4.6 trillion. That constitutes a 78% increase in per capita national healthcare expenditures from 7,681 US dollars to 13,653 US dollars. Now we'll look at a study from the Annals of Surgery in 2010 entitled National and Surgical Healthcare Expenditures from 2005 to 2025. And this predicts that there are 572 billion US dollars are spent on surgical healthcare expenditures in 2005, but this will rise to 912 billion in 2025. So in 2025, national healthcare expenditures will likely represent a quarter of the U.S. economy, and surgical healthcare expenditures will likely represent 1/14 of the U.S. economy. And these, of course, are enormous fractions, and they're things that the government is looking to really decrease. So now let's look at some background for my project specifically. Numerous attempts have been made to slow the national healthcare expenditures by both the private and public sectors. So federal and state legislation, for example, during the Clinton administration, they tried to pass laws creating health maintenance organizations, which are ways to decrease healthcare expenditures. And they also use prospective payment systems for both hospital and physician care. And then they also use implementation and expansion of managed care. However, none of these have seemed to curtail national healthcare expenditures, as can be seen by the studies we just looked at. However, the Obama administration has recently shown a newfound interest in reforming the healthcare system. And we've seen a lot of that in the news recently. So in 2010, the Patient Protection and Affordable Care Act, or PPACA, was passed. So what is this act? Well, here's an interesting part of it. This is a study from the New England Journal of Medicine in 2009. It looks at primary care and accountable care models, which are two essential elements of delivery system reform. So this study examined how to improve quality and coordination of care. And it suggests that we slow the growth of national healthcare expenditures by implementing delivery system reforms. That is, we may need to switch from our primary care model to our accountable care model. Now, what are these models? Now, the primary care model, which we use now, means that you go to your primary care physician or an internal medicine doctor, and they would see any problem you have, say, for example, a lower back problem. Then they would determine if this is serious enough to warrant you being referred to a specialist. And this is supposed to curtail costs by reducing the number of specialist visits. However, it hasn't really worked, so we may need to switch to an accountable care model. Now, what is that? So we'll look at this study called Accountable Care Organizations. And it says that it defines an accountable care organization as something that manages a full continuum of care and is held accountable for overall costs and quality of care for a defined patient population. So an accountable care organization would bring together all the different component parts of care for the patient. That is primary care, specialists, hospitals, home health care, etc. And to ensure that all of these parts work well together. So Obama's latest Healthcare Reform Act fosters pilot programs to extend the model from Medicare to private payers and Medicaid, which should help accountable care organizations become more of a factor in our healthcare. So why does this matter to the average person? So the accountable healthcare model, it groups together payers, provider, and patients all working together, and they define an episode of care for a set of medical services required to manage a specified condition over a finite period of time. Now, what does this mean? This means that specific patients will be provided all of the healthcare services they need for a certain condition, theoretically streamlining the process for the patient and cutting costs for the payers. This would obviously be a great thing for our economy because it would reduce the amount of money we are spending on healthcare. Now let's look at a study from the Journal of Arthroplasty in 2008 called An Analysis of Medicare Payment Policy for Total Joint Arthroplasty. Now this gets into more of what my project looks at, which is joint replacement surgery and how that affects national healthcare expenditures. So over 800,000 hip and knee arthroplasty procedures are performed annually in the United States. Medicare is the primary payer for these procedures, paying over 60% of them. The government will continue to scrutinize the costs and benefits until observational studies determine whether adherence to process of care measures leads to improved patient outcomes. And this is because so much money is being spent on these procedures, so the government will certainly look at them to determine whether or not they're an effective means of treating these illnesses. So why should we care? Well, recent reports in orthopedic literature have begun to define the role of patient and hospital characteristics responsible for adverse outcomes after total joint replacement surgery. This will allow hospitals to predict which patients are at risk for adverse outcomes before their surgery based on personal information such as age, weight, body mass index, and so on. These studies also underscore the importance of implementing care pathways that optimize the outcomes of surgeries and limit unnecessary resource use. And care pathways are a standardized set of steps that must be taken during an episode of care for total joint replacements. So what does this all mean? That means we're unaware of any reports examining the role of risk stratification on resource utilization at outcomes following total joint replacement surgery. In other words, no study has looked at how preoperative and intraoperative factors influence both the cost of surgery and patient outcomes. So the objective of our study is simply to investigate the resource utilization and the clinical outcomes after total joint replacement surgery for an episode of care in a defined patient population. So here are our hypotheses. We hypothesize that utilization of more resources is not correlated with improved outcomes, and that unexplained and unnecessary use in resource allocation is not correlated with improved outcomes. There will be increased resource use and worse outcomes in late adulthood patients with limited educational attainment and financial resources. And also that there will be increased resource use and worse outcomes in obese patients with heart, lung, and/or kidney disease. So the aims of our study are specifically to determine the variability in resource utilization that occurs during an episode of care. That is, which patients receive more or less resources and why. This will help us develop a novel risk stratification model, which is a model used to predict the use of resources and the success of surgery for a total joint replacement for an episode of care in a defined patient population whose health insurance coverage and medical care is provided entirely by the Cleveland Clinic Foundation. So the significance of our study will be that it should help hospitals predict which patients undergoing total joint replacement surgery will require an increase in resource allocation and who are at risk for worse outcomes. Now let's look at study eligibility. Patients will be excluded if they underwent revision total joint replacement surgery, so we're only looking at the initial surgery, and also those who required emergent adult reconstructive surgery. So to be included in the study, you have to have had a total hip arthroplasty or a total knee arthroplasty, or also a conversion of a prior hip surgery to a total hip arthroplasty or a unicompartmental knee arthroplasty. And then also these patients must have health insurance coverage provided entirely by the Cleveland Clinic Foundation for a defined episode of care. Our database query used the Cleveland Clinic EHP claims database, which is used to find all the pertinent charges and payments for the patient population. And then this will be used to link the episode of care for a patient population to specific medical information obtained from the EMR database, for which we used Epic. Now let's look at our study design. We took the 679 Cleveland Clinic patients that underwent total joint replacement surgery from 2007 to 2010. And we broke these up into total hip arthroplasties, total knee arthroplasties, previous hip surgeries converted to total hip arthroplasties, and unicompartmental arthroplasties. And then for each of these, we looked at the pre-op factors, the intra-op factors, and the post-op factors for each patient. Then we correlated this data with the charges and payments that we found from the financial database. So far, we have only gathered some preliminary data for which we examined the medical records of 52 patients from our defined patient population. So using Epic, we abstracted pertinent information on the patient's preoperative factors. These preoperative factors were organized into two distinct categories: sociodemographics and comorbid medical conditions. So first, let's look at the sociodemographic information we found. This information includes gender, age, race, financial status, educational attainment, employment status, etc. So I've included a few graphs here just to take a look at some of the more important parts. So let's look at the age group graph. Now, you can see clearly that 59%, or the vast majority, were in the age group of 55 to 64 years old. But our ages range all the way from 35 years to 74 years. And then we look at the procedures. These are broken up into left and right total hip arthroplasties, as well as left, right, and bilateral total knee arthroplasties. And you can see that the procedures are pretty well split across the board, other than the bilateral total knee, which is at 6%, and the right total knee, which is at 10%. The others are fairly well-rounded. Now let's look at the comorbid medical conditions. This category consists of a patient's medical conditions, such as any heart, lung, or kidney diseases, as well as body mass index and other factors. So if you look at the comorbidities, you can see that the first is hypertension, which occurred in 40 of our patients, or 61.2%. But then after this, 61.2% is quite a majority. But after that, it drops off very rapidly. We go down to gastroesophageal reflux disease, which is 28.6%. And then down to hyperlipidemia, which is 22.4%. But then after that, it goes down to 12%, and then 8% and 6% for all the different comorbidities. So clearly we have a wide range of comorbidities, but they're affecting a very small percentage of our patient population. Then if you look at patient body mass index, you can see that the vast majority of our patients are obese. That is a body mass index of over 30. We had no patients that were underweight. So from this data, we can conclude that a high level of variability exists between our patients undergoing total joint replacement surgery and the defined patient population. As a result of this variability in patients, the resource utilization for each episode of care will fluctuate as well. The eventual goal of this study is to correlate the distinctions between patients to the resource utilization and outcomes of each total joint replacement. This information will be used to create a risk stratification model, allowing hospitals to predict which patients will require additional resource use and are at risk for adverse outcomes. So thus far, this study has just proven that considerable patient variability exists, which is a key step towards developing our model. So I would like to thank everyone for listening. And I would also like to thank my mentor, Dr. Mark Freumsen, the resident I worked with, Dr. David Kovacevic, Mary Lagrasso, Deanna Treehouse, and the remainder of the orthopedic department and the Office of City Education Initiatives for helping to make my internship experience so enlightening. Thank you.